Good evening. I hope and I believe all of you are doing well. A quick note whether the audio visual is all good. All right. Okay. So happy evening, everyone. Welcome to today's YouTube live session where we are going to talk about, I think this will be the last part of ANS Pharmacology. We have already discussed the parasympathetic system, the cholinergic and the anticholinergic drugs. And today we'll be focusing on sympathetic system. The links of part 1 and part 2 have been given in the description of this video. So whenever you're reading ANS Pharmacology, you can combine these 3 sessions and you can see them together. Okay. And today we are focusing on the sympathetic system, including the effects of the sympathomimetics on basically the heart rate, the blood pressure, like one of you had asked on the Telegram group. So let's start with it, and let me also tell you that the next class that we have today, it is on Unacademy at 7:30 p.m. We have the free class on Unacademy app. It's a special class. And today we have KBMD on pharmacology, which will be basically focusing on the PYQs, that is the previous year questions that have been asked in AIIMS and in NEET PG. So the questions will be based on that, and this will be basically a test for you to help you realize that how much of it we are actually retaining of what we are reading. So all the topics that we have covered in pharmacology so far in the daily targets, general, ANS, CVS, CNS is what we will be focusing on in the today's KBMD. So basically, it's like a post test for all of you after combining this much of pharmacology. It's at 7:30 p.m. If it asks you for any unlock code, you can use the code Dr. Nikita. Okay, Dr. Nikita is the code. So we have the next class at 7:30 p.m. All right. So let's start with basically a quick revision of the sympathomimetic agents. Okay. So we'll be talking about the sympathomimetic agents. I'll try to reduce the confusion of, the drugs in ANS pharmacology. So basically the first point to be remembered here is, see, whenever you talk about the drugs which have Z, like ZO or ZE in their spelling, or X in their spelling, these are the drugs which are basically antagonist drugs. Okay, these are the drugs which are antagonists. So for example, if I have to give you an example like prazosin, okay, because we tend to get confused in the drugs itself. What is the action of these drugs? So when I say prazosin, okay, so when I say prazosin, the Z tells you that basically ये zero करने वाला action है. S tells you zero, it is doing to the sympathetic system. It is inhibiting the sympathetic system. Okay. So basically remember ZO is like zero, that is inhibitor. It is sympathetic system ka inhibitor. So prazosin is sympathetic wala, that is alpha mein hai ye. Okay, this is because the beta blockers wale hain, they are generally like propranolol, atenolol, timolol. So LOLs, right? So this is your alpha 1 blocker. Okay, this is alpha 1 blocker. Now, similarly, what was that antagonist that we saw at M1? What is the M1 blocker that we saw in cholinergic, anticholinergic drugs, the parasympathetic system? M1 stomach wala, that is pyranzapine, right? Pyranzapine. Again, remember ZE zero karne wala. Okay. PI is parasympathetic system ko or IN is inhibitor. So it is antagonizing the parasympathetic system, prazosin, pyranzapine. These are at alpha 1 and M1. Okay, alpha 1 and M1. Okay. And we'll come to rest of the drugs also as we discuss, and we'll try to decrease the confusion. Okay, so let's talk about the sympathomimetic agonist first, the agents first. So again, like the cholinergic drugs, we have direct acting, we have indirect acting. What is direct acting? Direct acting is basically the one which is acting on the receptors directly. Indirect acting means it is not acting on the receptors, but indirectly by increasing the catecholamine levels, it is acting as indirect sympathomimetic agent. Okay, so indirect में अगर कुछ important examples हमको देखने हैं, so amphetamine basically acts by releasing the norepinephrine. We had seen this in the last class. So you have the norepinephrine released in the vesicles. Amphetamine displaces this and it pushes out the norepinephrine. Cocaine, very, very important. Again, something we have discussed. Cocaine acts by inhibiting the reuptake. Okay, cocaine acts by inhibiting the reuptake. So basically, indirectly, they are increasing the catecholamines, either by increasing the release or by inhibiting the uptake. Amphetamine has been included basically in the mixed type of sympathomimetic agents, like receptor pe also, and indirectly by causing the displacement. Now, direct acting in the sympathetic system, basically we have alpha receptor and we have beta receptors that also we have discussed in the last class. So not discussing again in the details. So we will be seeing alpha agonist and beta agonist. So even in alpha, we have non-selective, we have alpha 1 selective and alpha 2 selective. So basically remember norepinephrine. So we had discussed this point that norepinephrine, it is non-selective alpha because basically remember that norepinephrine has no beta 2 action. Okay, we had discussed that norepinephrine is no beta 2 action. It is no methyl group as compared to epinephrine. Epinephrine, E for everything. It acts on all the receptors, alpha also and beta also. That is why norepinephrine we are including in the alpha agonist only. Again, then phenylephrine. Now, if you get confused anytime, whether this is alpha agonist or it is alpha blocker, right? If you get confused with phenoxybenzamine, phentolamine, phenylephrine sounds very similar to like norepinephrine or epinephrine. That is basically the ephrine tells you that this is similar to this epinephrine, norepinephrine. That means it is an agonist, it is not an antagonist, right? Like similar to buprenorphine. Buprenorphine has a spelling similar to morphine. So it is like morphine, it's a partial agonist, right? It's a partial agonist, okay? So remember that phenylephrine, again, INE wala yahan pe, this is alpha 1 selective agonist. Alpha 2 selective are your di wale drugs, di ya do wale drugs, right? Like you have a methyl dopa. Alpha methyl dopa, do is 2, di is 2. So tizanidine, again dine, that is di, that is your alpha 2 selective agonist. Now that was about alpha. Now coming to beta agonist. Okay, so even in beta we have non-selective, beta 1 selective and beta 2 selective agonist. So non-selective here is isoproterenol. Okay, iso we have discussed before. Iso means equal. Iso matlab equal. It acts on equal action on beta 1 and beta 2. Beta 1 selective, though it has some beta 2 action also, is dobutamine. Therefore, we said that it is used in cardiogenic shock. Remember dobutamine. It is not dopamine. It is dobutamine. And beta 2 selective is albuterol. Okay, like your beta 2 selective agonist, salbutamol, albuterol. These will be basically used in asthma. They'll be used as tocolytics because they are acting on the smooth muscle, causing the relaxation. Okay, clear with everyone the drugs here basically? Yes. Is this clear with everyone so far? Now we'll keep reinforcing these concepts as and when we discuss this topic. Okay. Now giving you a quick overview. First I'll give you a quick overview of the agonist and the antagonist. हमने alpha agonist देखा, अब हम alpha blockers देख रहे हैं. So in alpha blockers, again non-selective. Okay. So again what we have here is just give me a minute. Again here we have irreversible and reversible. So remember this X wala, O wala, that is 0 wala tells you that these are basically the antagonists. These are blockers. So out of this, basically phenoxybenzamine is irreversible. Remember X matlab complete block and phentolamine is reversible. Okay, so remember these are OX ya O wale drugs. Unlike phenylephrine, which is like epinephrine, it's an agonist. This is blocker. Phenoxy is X, complete stop. That tells you that this is irreversible. Alpha 1 selective, we also already said ZO मतलब zero करने वाला, sympathetic को inhibitor at alpha 1. Alpha 2 selective is yohimbine, that is again bi वाला, bi को inhibit करने वाला. ठीक है, ये DI या DO नहीं है, ये है bi वाला. Beta blockers, non-selective propranolol, we'll see the mnemonics for that कि beta 1 selective कौन से है. We have the mnemonic which is NBE का bump, beta 1 selective, and beta 2 selective is butoxamine. Okay, TO and X. Butoxamine is beta, TO is 2, X is X. So butoxamine is basically your butoxamine is basically beta 2 selective blocker. Okay. Here with everyone regarding the blockers, the antagonist alpha में non-selective irreversible phenoxybenzamine, reversible phentolamine. Alpha 1 selective is prazosin. Okay, and then we have the next. Alpha 2 selective is yohimbine. Beta में non-selective is propranolol. Okay, beta 1 selective NDE ka bum. I'll tell you the entire mnemonic, and then we'll have butoxamine. Okay, that is beta 2 selective blocker. Okay, now coming to this one. Okay, are you guys able to see this? Let me please give me a quick thumbs up if you're able to see this. We'll just try and revise the sympathomimetic agents, the adrenergic drugs, and then we'll see the effects, okay, on the heart rate and the blood pressure. All right, so let's see this. So in sympathomimetic agents, just give me a minute. थोड़ा सा blur है. Let's try if we can. I hope we should be able to see this now. Okay. So catecholamines, direct acting sympathomimetic agents, that is receptor में the catecholamines. Endogenous from the body we have adrenaline, noradrenaline and dopamine. Exogenous is dobutamine, phenoldopam and isoprenaline. Okay, dobutamine, what did we say? Where does dobutamine act? Dobutamine is predominantly beta 1. Phenoldopam, okay, this phenoldopam is at dopa 1, okay, D1 receptor. Non-catecholamines, then comes your drugs, basically alpha 1 agonist. Alpha is a vasoconstrictor, right? AC, it's a vasopressor agents. You also have midodrine, which comes here. Okay, you have midodrine, which comes here. Mydriatic phenylephrine. Remember, phenylephrine is like epinephrine, it's an agonist. Okay, so this is your alpha 1. It is a mydriatic. Remember your dilator. Adrenergic wale drugs are all dilatation and relaxation. Pupillary dilatation karega. Alpha 2 agonist. You have your di-endo, clonidine, methyl dopa used in hypertension. Apraclonidine, brimonidine, we have seen yesterday in glaucoma. What was the side effect with apraclonidine? Follicular conjunctivitis, lid retraction. Brimonidine was brain inhibition, that is brain depression. Produce sedation, dexmedetomidine, again your DINE wala. Okay, that's your dexmedetomidine. It is produces sedation. Now remember that these are also used as nasal decongestant like your xylometazoline, oxymetazoline, right? The Otrivin nasal drops. Okay, so these are used as nasal decongestants also. Now going to the beta wale mein, beta 2 is important. Beta 2, remember the smooth muscle relaxation. So you have bronchodilator, uterine relaxant, salbutamol, salmetrol, they cause bronchodilation. Uterine relaxation, isoxaprine and ritodrine. Beta 3, we have already seen mirabegron, BE is B3. So basically it relaxes the bladder. So it is used in overactive bladder. Okay. Now indirectly acting, that is increasing the levels, reuptake. Remember cocaine is reuptake inhibitor. Displacement is tyramine. Can someone tell me the importance of tyramine? Yes, Dr. Priya, at least the drugs that we are discussing should be learned. Tyramine, basically, if you are asked about cheese reaction, okay, cheese reaction, yeah, tyramine has high content basically in cheese, old cheese, red wine. It can lead to increased levels of norepinephrine, can lead to high blood pressure because basically it is indirectly acting sympathomimetic. Especially when we give this with MAO inhibitors. Okay, especially when we give this with MAO inhibitors because tyramine is metabolized by MAO. Okay, so ये वाला reaction interaction is very very important. Can you tell me, now you're reading antimicrobials today? Antimicrobials, tell me which antimicrobial has a MAO inhibitory action? Which antimicrobial has a MAO inhibitory action? I able. Yes, very good. Very good, Anjana. That is linezolid. Okay, that is linezolid, which has MAO inhibitory action. Okay, which has MAO inhibitory action. Okay. All right. Now, mixed acting. Remember, amphetamines is where we spoke about. Even ephedrine comes here in mixed acting. Amphetamine ka derivative basically methylphenidate. Where is this used, methylphenidate? It is used in ADHD. Okay, attention deficit hyperactive disorder is where it is used. Okay. So, are you clear with at least the summary of the drugs, that how you will remember whether it is alpha 2 agonist, whether it is alpha 2 antagonist, alpha 1 agonist, or it is blocker, right? I hope this is clear with everyone. Now, these are the important tables. Time and again, I emphasize about the importance of these tables from Kadzang. Okay, they are very, very important. So, let's quickly revise this. Alpha 1 agonist, हमने कहा midodrine, and we have phenylephrine, right? It's like epinephrine. These are alpha 1 agonists, so they will cause vasoconstriction. So basically, they will increase the blood pressure. Okay, they will increase the blood pressure. So where will we use them? In hypotension. Okay, it will be used in hypotension. Apart from that, phenylephrine, it can be used for short-term maintenance of blood pressure in acute hypotension, and intranasally it is used as a decongestant. So आप वो Vicorel वगैरह में भी देखोगे phenylephrine is present. If there is nasal congestion, so to decongest, basically to cause vasoconstriction, we use this alpha 1 agonist drugs. Okay, we use this alpha 1 agonist basically to cause vasoconstriction. Okay. The next that we have alpha 2 agonist. How do we identify alpha 2 agonist? Either by di or do. So you have clonidine, alpha methyl dopa, dexmedetomidine, tizanidine, apraclonidine, and brimonidine. Okay, and brimonidine. So all of these are basically di ya do wale drugs. Okay. And so these drugs, alpha 2 agonists, they decrease the release. So they are central sympatholytic. So they lower the blood pressure. So they are used in hypertension. That is, clonidine is used in hypertension. Alpha methyl dopa also used, right? Dexmedetomidine, sedation. We already saw tizanidine. You'll see many times as muscle relaxant. And apraclonidine, brimonidine is glaucoma. Coming to beta agonist, dobutamine beta 1, beta 2 is albuterol, we have salbutamol वगैरह, and beta 3 is mirabegron, right? Beta 3 is mirabegron. Dobutamine beta 1 in the heart increases the contractility, so used in cardiogenic shock and acute heart failure. This is used in asthma, beta 2 agonist. It is used as tocolytic also, okay? And beta 3, this is used in urinary urgency. Basically, it reduces the bladder tone, okay? And look at this. This has been asked in your exam. All the beta receptors, basically they act by increasing the cyclic AMP. Okay, they are increasing the cyclic AMP. That is GS subtype of receptor is what it is. Dopamine mein you have D1 agonist phenol dopam, whereas D1 basically vascular smooth muscle relaxation it causes. So it's used in hypertensive emergency, very, very important. And D2 is basically your bromocriptine. D2 agonist bromocriptine. So that is where we use in prolactinemia, Parkinson's, जहां आपको dopamine बढ़ाना है. You want to decrease prolactin because dopamine is inhibitory to prolactin. Parkinson's dopamine decreases. So we use bromocriptine there. Okay, that is D2 agonist. Okay. Now coming, where are these tables from? These are from Kaizen. Okay, so whenever you are reading pharmacology, always try to do the tables from Kaizen also. Whatever chapter you are finishing, you should revise it from the tables of Kaizen. Very, very important. Okay, now this is basically important. One of you had asked the actions of the sympathomimetic drugs on the blood pressure and the heart rate. It's very easy. See, systolic blood pressure, basically systolic is the cardiac output. So cardiac output is beta 1 receptor ka action. Diastolic blood pressure means the vessel ka tone. So in the vessel, what receptors we have? We have alpha 1 and we have beta 2. Alpha 1 constriction, beta 2 dilatation. And then we have the effect on the heart rate. The direct effect on heart rate is yes, Ravi Shankar, bromocriptine is also in diabetes mellitus. Okay, it's a new experiment that has been done. Direct action heart wala beta 1 and reflex wala action is basically by the M2 receptor. Okay, and then we'll see the net effect. Adrenaline, noradrenaline, and you have isoproterenol. Okay. Okay, so tell me now. Yes, Dr. Priya, only the tables from Kaizen. Read your primary resource and then revise it from Kaizen. Okay. Adrenaline acts on all the receptors, alpha also and beta also. So beta पे act करके systolic blood pressure बढ़ाएगा. By acting on alpha and beta both, it is counteracting constriction and dilatation. So remember, diastolic blood pressure not changing much. Increasing the heart rate by acting on beta 1. So basically, it is increasing the heart rate. Noradrenaline has no beta 2 action. That means it does not cause vasodilatation, but it has alpha action, causes vasoconstriction, increases the diastolic pressure. Okay, it increases the diastolic pressure by causing vasodilatation. Right, so by causing vasodilatation, it is the diastolic blood pressure is diastolic blood pressure, it is changing. Only, what do you want me to explain, Ravi? Okay, so look at this one. Okay, look at this graph if you are given like this. So you have isoproterenol. First, remember what is the action? It is beta 1 and beta 2. Epinephrine is everything. Norepinephrine is no beta 2 action. So when you give isoproterenol, basically the beta 2 action, it is vasodilatation, decreasing the blood pressure. Okay, so when you give beta blocker, this is pre-treatment with a beta blocker, you can see the blood pressure will not decrease because beta relaxation is not happening. When you give alpha blocker, the effect is the same. This shows you that isoproterenol has no alpha action. So whether you give alpha blocker or you don't give alpha blocker, it's not gonna change the effect of isoproterenol. That is how the questions will be framed. Epinephrine, it has all the actions. So पहले जब starting में high levels है in the blood, it has the alpha action. It increases the blood pressure. Then at low doses, beta 2 is more sensitive. It vasodilatation decreases the blood pressure. So you see the biphasic response. Now, if you give alpha blocker, pre-treatment with alpha blocker, the blood pressure will not increase. It will only decrease. And this is something called as Dale's vasomotor reversal, right? But if you give an alpha blocker and you give epinephrine, there will be decrease in blood pressure rather than increase in blood pressure. If you give a beta blocker, the initial response will be there, the later response will not be there. So only the increase in blood pressure will be seen. So remember that Dale's vasomotor reversal is basically if you give alpha blocker and then you give epinephrine, so it only causes the decrease in blood pressure. There's no increase in blood pressure. Norepinephrine, basically it has no beta 2 action, so no vasodilation. So it's increasing the blood pressure here, right? It's increasing the blood pressure, the diastolic blood pressure. If you give an alpha blocker, norepinephrine has alpha action. If you give alpha, the effect will be diminished. If you give beta, the effect will be the same. That tells you that norepinephrine में beta 2 action नहीं है. So even if you give beta blocker, the response is not going to change. Okay. So remember that these are the important graphs and you get a lot of questions on this. So basically alpha adrenergic blockers will not have any effect on a drug which is pure beta agonist like isoproterenol. Alpha adrenergic blockers, they reverse the vasoconstrictive action, that is your vasomotor reversal. Now these are the graphs from Katzung. Okay, let's have a look at this graph. What are these graphs showing? So look at this graph. Thoda sa complicated hai, but try to understand. You get a lot of questions on this. So look at this one. The blood pressure and the heart rate. This is the heart rate which is shown. This is the blood pressure which is shown. So when we are giving phenylephrine, what is happening when we are giving phenylephrine? You can see that the blood pressure is increasing. Okay, the blood pressure is increasing. The heart rate is also increasing. Okay, the blood pressure increasing, heart rate increasing. Now, if you are asked to identify which is phenylephrine, which is epinephrine, and which is isoproterenol. Now, how will you differentiate this? Let me just tell you the differentiating points. So, the differentiating points are with phenylephrine, you can see that the heart rate is decreasing from 170 to 160. With epinephrine, it is increasing, and even with isoproterenol, it is increasing. Why is it so? Because what is phenylephrine? Phenylephrine, like epinephrine, but one wala, it is alpha 1 agonist, right? It is alpha 1 agonist. The vasoconstriction, right? So that is why it is causing vasoconstriction. It is increasing the blood pressure. The increase in blood pressure is decreasing the heart rate, right? So remember that phenylephrine is decreasing the heart rate. Epinephrine, it is increasing the blood pressure from 135 to 190, and then there is a decrease also. There is increase and decrease, the alpha 1 action and the beta 2 action, right? So you will see both, and the heart rate is increasing. There is beta 1 action also. Isoproterenol. What is isoproterenol basically doing? Isoproterenol is beta 1 and beta 2. So look at the heart rate increasing so much, 150 to 240, and there is a decrease in blood pressure because it has a beta 2 action also. So the vasodilatation that leads to significant decrease in the blood pressure, and it also leads basically to increase in heart rate. Okay, increase in heart rate. So if you have to differentiate phenylephrine from the rest of the two, remember, phenylephrine will cause decrease in heart rate because it's vasoconstrictor. Epinephrine will increase, it has a biphasic response. It increases the blood pressure, decreases the blood pressure. And isoproterenol, it decreases the blood pressure significantly. Okay, it decreases the blood pressure significantly and the heart rate increases significantly. Okay, very, very important. Chalo, so that was about these drugs. We have done these drugs. Now let's go to the antagonist, the alpha antagonist. Okay, try solving questions on ANS pharmacology to understand this concept. Alpha adrenergic antagonist, phenoxybenzamine, X wala irreversible, phentolamine reversible. Okay, azocin, terazosin, doxazocin, these are alpha 1. Tamsulosin is also alpha 1, but remember this is important, it is alpha 1A selective, alpha 1B कम है, तो blood pressure पे effect कम होता है. So if you have basically a patient who has BPH and there is no hypertension, we will give tamsulosin. If you have patient with BPH and hypertension, you want to decrease the blood pressure also, then we will give prazosin, doxazocin or terazosin. Okay? Because remember that very, very important questions. These drugs, because they block the alpha 1 receptors, so they do not allow the blood pressure to increase when the patient stands. So there is orthostatic hypotension. Orthostatic hypotension, very, very important. First dose effect, it is maximum with the first dose. So we give at bedtime so that patient does not have to stand. So we give at night. Okay. Phenoxybenzamine, phentolamine, basically these are used in pheochromocytoma. Okay. Yohimbine, BINE is your alpha 2 agonist, alpha 2 antagonist, sorry, and it has a role in male erectile dysfunction. Labetalol is alpha plus beta both blocker. So remember that when you write labetalol, remember this is important, alpha plus beta both. It is lowers alpha and beta both. Okay, it's used in hypertension. Okay. Now coming to the next topic, the last topic here, which is beta blockers. Okay, how will you remember beta blockers? Okay. Beta blockers, basically you want to remember which are beta 1 selective and which are non-selective. Why is the importance of knowing that? What is beta 1 selective blockers and which are non-selective blockers? See, beta blockers which are beta 1 selective, that means preferentially they will act on the heart itself. No bronchoconstriction will be there, no metabolic effects will be there. Right, when you give a non-selective beta blocker like in diabetic patient, it will not mask the hypoglycemia symptoms which are because of your beta 2 action. So beta 1 selective, we need to know this for this reason, and the mnemonic is NBE ka bum. Okay, remember the mnemonic is NBE, right? NBE ka bum jab aata hai, it is cardioselective. It directly affects the heart. So what is NBE ka bum? What is N for? N is nebivolol or N is nadolol? What is N for? What is NBE ka bum for? Remember, N is for not nadolol. N is for nebivolol. When I say nebivolol, again it is beta 1. When I say nadolol, remember nado is both. It is beta 1 and beta 2 also. The rest of them you can see are the alphabets up to M. So basically beta blockers with A to M will be mostly beta 1 selective. After M, except nebivolol, they will be non-selective. Okay, so you have bisoprolol, esmolol. What is C for? What is C for? C is carvedilol or C is carvedilol or is it celiprolol? Remember, C is celiprolol, not carvedilol. Celi tells you celi is selective. Okay, celi is selective. SEL, carvedilol is alpha plus beta both. Then you have acebutolol, then you have betaxolol, atenolol, and M for metoprolol. Okay, M for metoprolol. Timolol, because it is starting with T after M. So remember, it is non-selective. Timolol is non-selective. Propranolol, pindolol, all of these हम यहाँ पे list में जब देखेंगे. Okay, so look at the selectivity. After M, all these drugs are non-selective except nebivolol. So remember, nebivolol is beta 1. Rest after M, nadolol, penbutolol, pindolol, propranolol, sotalol, timolol, all of them are non-selective. Okay, all of them are non-selective. आगे में A to M में carvedilol and labetalol are the ones which are alpha plus beta both. Labetalol is alpha plus beta. Okay, very, very important. Okay, now talking about which drugs have partial agonist activity and which have local anesthetic activity. Okay, so partial agonist and local anesthetic, remember the drugs which have both the properties. Which beta blockers have partial agonist activity? Which have local anesthetic? That means what is the local anesthetic property due to? Basically the membrane stabilizing action. Okay, the membrane stabilizing action is local anesthetic. So partial agonist and local anesthetic, that is PALA. Remember, these are the drugs which have both the properties. So P is for pindolol, A is for acebutolol. Remember, ACE is an acer drug. It is present everywhere. MSA also and PA also. Labetalol is the one which has both the properties. So pindolol, acebutolol, labetalol have both the actions. Which are the drugs which are local anesthetic action, membrane stabilizing? Remember, for giving local anesthesia, you have to be pro, like expert, pro at giving local anesthesia. So remember that you have propranolol also, propranolol and me too. Okay, that is me too is pro at giving LA. So me too is metoprolol. Remember, these are the drugs like metoprolol, propranolol, and the pala drugs. These are the ones which are local anesthetic. Pala drugs have partial agonist activity also. That is pindolol, acebutolol, and labetalol. Now, if I ask you this question, think logically and tell me that in glaucoma, do we use beta blockers? Are beta blockers used in glaucoma? Yes or no? If yes, what is the mechanism of action of beta blockers here? Are beta blockers used in glaucoma? Yes. What is the mechanism of action? Decrease aqueous production. We have seen ABC other drugs, alpha agonists, beta blockers, carbonic anhydrase inhibitors. Which is the beta blocker that we use generally? That is timolol. Why do we prefer it over propranolol? Why do we prefer it over propranolol? Propranolol is also a beta blocker. Why do we prefer it? Because remember that propranolol has local anesthetic action, the membrane stabilizing action. So it will decrease the corneal sensation that will affect the eye. Okay. So remember propranolol hum nahi denge. That helps you to remember that propranolol has a membrane stabilizing local anesthetic action. Timolol does not have that. Okay. Absolutely right, Sambhav. So corneal anesthesia करेगा इसीलिए propranolol नहीं देते हैं, timolol is preferred. Okay. So me too pro at giving LA and Pala are both. Pindolol, acebutolol, labetalol, they are both. Okay. So local anesthetic you can see acebutolol, labetalol, metoprolol, and you have pindolol, right? And you have propranolol. Okay, and you have propranolol. Okay. Pala drugs have both. Which is the shortest acting beta blocker? Esmolol. Okay, remember esmolol is the shortest acting. Okay, it is generally given intraoperative. जब आपका पेशेंट है समझो थायरोटॉक्सिकोसिस वगैरह का पेशेंट है टू कंट्रोल द ब्लड प्रेशर अरिथमियास इंट्राऑपरेटिव अरिथमियास कंट्रोल करना है थायरोटॉक्सिकोसिस में we give esmolol. Longest acting, remember Nadal. Okay, Nadal who plays for a long time on the ground. So remember Nadolol is the longest acting. Nadolol is the longest acting. Okay, shortest is esmolol, longest is Nadolol. So esmolol का half life होता है सिर्फ 10 minutes. It is given IV only. Okay, it's given only IV. Okay. So what is the difference basically between, if I ask you what is the difference between atenolol, metoprolol and propranolol? Now propranolol P after M, so it is non-selective beta blocker. Atenolol is beta 1 selective, metoprolol is beta 1 selective. Out of these, which has partial agonist activity? None. Which has local anesthetic action? Me too, pro at giving LA. So metoprolol and propranolol have both. They both have local anesthetic action. Okay, they both have local anesthetic action. Okay. Now, which are the third generation beta blockers? First generation is non-selective. Second generation is beta 1 selective. Third generation means they have additional actions, additional vasodilatory action. So, additional alpha blocker, it is your labetalol and carvedilol are important. Remember AB and you have carvedilol. Release of NO, another important question. Nebivolol. So remember NO is N wala drug. Nebivolol is a NO releasing drug. Okay, NO releasing drug. And another important question here, which is a beta 2 agonist also. Remember celiprolol. Celiprolol is celi. Okay, it is a celi that is a friend to beta 2 receptor. It is beta 2 agonist also. Okay, it is beta 2 agonist also. Clear with everyone? Okay. So now coming to this table, the final table. If I ask you this question, let me see how many of you remember this. Which is a beta 2 selective blocker? Which is a beta 2 selective blocker? PDF हाँ दे दूंगी PDF टेलीग्राम ग्रुप पे. Which is a beta 2 selective blocker? Is it albuterol? Is it salbutamol? Is it labetalol? Sekhar, dobutamine. Remember where it is used? Cardiogenic shock. So it is stimulating the heart. It is beta 1 agonist. It is agonist. Which is beta 2 selective blocker. Celiprolol we said is beta 1 selective blocker with beta 2 agonist action. Sambhav metoprolol is beta 1 selective, cardio selective, right? किसी का ध्यान है? Yes, finally I see someone. Very good, Aman. So it is butoxamine. Okay, it is butoxamine. Remember, bu is beta, TO is 2 and X is the blocker. So it is beta 2 selective. Salbutamol is your beta 2 agonist. It's used for bronchodilation, right? Salbutamol तो agonist है ना, हमको relax करना है तो हमको beta 2 agonist है salbutamol. ठीक है, it is butoxamine. So look at this one. Let me zoom this for you. It is butoxamine is beta 2 more than beta 1. ठीक है. Partial agonist activity wale, that is intrinsic sympathomimetic activity. Remember the pala wale drugs. You have pindolol, acebutolol, you have labetalol also, and you have celiprolol also. Okay, celiprolol also. And बाकी कौन से drugs हैं? बाकी ठीक है. Remember that beta 1 selective is nabivolol. These are beta 1 selective. After M they are non-selective. Okay, after M they are non-selective. ठीक है. So ये हो गए beta blockers. An important point to remember here, in your catecholamine synthesis, the rate limiting step is tyrosine hydroxylase, the inhibitor of which is mettyresone. So basically it reduces the synthesis of these catecholamines. So it's basically used to lower the blood pressure and pheochromocytoma में catecholamines कम करने के लिए use करते हैं. ठीक है. So ये हो गया. Remember, these are the various uses of beta blockers. Let's quickly revise this. So what do we have here? Propranolol is non-selective, right? Where do we use beta blockers? Hypertension. They decrease the blood pressure, depressing the heart. Very important. Remember migraine also and hyperthyroidism also. Because propranolol specifically, it converts your T4 to T3 conversion. So it's used in hyperthyroidism, angina, decreasing the cardiac work, MI, very, very important. Also remember for performance anxiety, right? For performance anxiety, tremors वगैरह के लिए हम use करते हैं. Because the tremors are because of the muscle contraction, the spindle which is getting activated, the muscle spindle. Nadolol, pindolol are both. Timolol is non-selective. These are beta 1 selective. Atenolol, bisoprolol, esmolol, metoprolol. Up till M, they are beta 1 selective. Then you have acebutolol, which is beta 1. It has both partial agonist activity also and local anesthetic action also. Nebivolol is your NO releasing drug. And alpha and beta blocker both is labetalol and carvedilol. Okay, carvedilol and labetalol. Carvedilol is cardiac use. Okay, remember it's used for the heart. Cardiac use, it has antioxidant property also. Okay, it has antioxidant property also. ठीक है. So ये था हमारा beta blockers, alpha blockers, agonist, all of them. Just remember the tricks. Like if you get confused between phenylephrine, phenoxybenzamine, phentolamine, all of these are basically आपका alpha वाले पे. Phenylephrine is like epinephrine, so it's an agonist. Phenoxy, phentol, 00X wale, they are the blockers. Okay, they are the blockers. All right. We have seen the mnemonics for beta blockers. Okay. All right. So this completes our ANS pharmacology. Also remember the effects on the heart rate and the blood pressure, the Dale's vasomotor reversal. And revise ANS pharmacology. Keep revising it till you have all the tricks, well ingrained in your brains so that you don't forget them. And we'll have the KBMD, which will include the ANS pharmacology also based on the previous year questions today at 7:30 p.m. Okay. So it's going to be a quick quiz to realize how much of, what we read, we retain. So see you at 7:30 p.m. on the Unacademy app for the free live class, KBMD in pharmacology of whatever topics we have covered so far. All right. So thank you so much, everyone, and goodbye. Take care and keep